It's Medicosis Perfectionalis one more time. Today we'll talk about class 3 antiarrhythmics, the potassium channel blockers such as amiodarone. We are here. Since this is class 3, it affects the muscles of the ventricle, and therefore you can use it for Wolff-Parkinson-White syndrome, but you do not use class 2 or 4 for WPW syndrome. Let's talk about amiodarone. Amiodarone is one of the class 3 antiarrhythmics, the potassium channel blockers. You have amiodarone, dronedarone, and sotalol. It's alol, not olol. Great. Antiarrhythmic. It blocks the delayed rectifier potassium channel, leading to delayed repolarization, which will prolong the effective refractory period. QT interval prolongation will lead to torsades-de-Pointes. What's the solution? Give magnesium sulfate. What are the clinical use of amiodarone for atrial and ventricular arrhythmia? If you look at here at the graph, this is a potassium channel blocker. As you know, potassium normally enters during phase 3. So this will slow down the slope of phase 3. It becomes more elongated, takes more time. What are the adverse drug reactions of amiodarone? It has a very long half-life with an enormous volume of distribution. It's everywhere and stays there forever. It contains iodine. It has high tissue protein binding, which will give it an even very longer half-life. It's toxic to your thyroid, your liver, and your lungs. Toxic to the thyroid can cause hypothyroidism or hyperthyroidism. Toxic to your liver can elevate your liver enzymes and cause drug-induced hepatitis. Toxic to your lungs can cause interstitial pulmonary fibrosis. How do I manage it? First, you have to check the patients regularly for the thyroid function tests, liver function tests, and pulmonary function tests. TFTs, LFTs, and PFTs, please. Also, this nasty amiodarone in the liver can interfere with the clearance of digoxin, warfarin, and phenytoin. So, when you give amiodarone, there is increased risk of digoxin toxicity, warfarin toxicity, and phenytoin toxicity. It can lead to blue-gray discoloration of the skin, corneal deposits, prolong the QT interval leading to torsades-de-Pointes. What's the solution? Give magnesium sulfate. Class 3 includes dronedarone, sotalol, dofetilide, ibutylide, and of course amiodarone. Dronedarone is very similar to amiodarone, but side effect sudden cardiac death. Ooh. Dofetilide and ibutylide uses only in the hospital for cardioversion. This is for the severe stuff. It's not for the faint-hearted. Converts AFib and atrial flutter to normal sinus rhythm. That's amazing. Side effects include torsades-de-Pointes. You know exactly what to do. What if magnesium sulfate is not among the choices? What should you do? We'll talk about that later. Or you know what? Let me give you the answer right now. You can go with class 2 or class 4 antiarrhythmics. Yes, the beta blockers or the calcium channel blockers. Next, you have sotalol. It's a combo. Class 2 and class 3. It's alol similar to olol. So it has beta blockers properties, which will lead to decreased conduction at the SA node and the AV node. Also has a potassium channel blocker properties, which will prolong the effective refractory period and the action potential duration. Clinical use include life-threatening VTAC and AFib. Side effects, same as beta blockers, same as potassium channel blockers. Thank you for watching. In the next video, I'll talk about the calcium channel blockers such as verapamil or diltiazem, but not nifedipine.